Cool. So we'll start off with the definition of endemic mycoses. So according to the European Confederation of Medical Mycology, endemic mycosis has 4 distinct features. The first is that it's a group of infections caused by thermally dimorphic fungi. So what does that mean? It means that they're a unique group of fungi that respond to shifts in temperature by converting between the hyphal form, so that's the mold form, at temperatures of 25 to 30 degrees, to the yeast form at temperatures between 35 and 37 degrees. This transition between the mold and yeast form is called the phase transition. And it's thought that this transition is essential for virulence of the fungi. And when it's in the yeast form, it upregulates genes which are involved with avoiding host immune defenses and thus being able to cause disease. So they have geographical distributions that's restricted to specific regions. And the reason for that is it's dependent, as we'll talk about when we go through risk factors for these endemic mycoses, that humidity, precipitation, and soil water storage all influence the environment in which these fungi can grow. The third thing is that it can cause disease in both healthy and immunocompromised hosts. So this is important to remember, because it's not just patients who are severely immunocompromised that can get these endemic mycoses. Perfectly healthy patients can also present with systemic endemic mycoses, and we'll talk a bit about that when we do the risk factors. And the last thing is that it increases mortality if it's not diagnosed and treated early. So the picture on the right here is just illustrating in the environment or in the lab culture, mold is cold, so that's what it looks like. That's the mold form in the lower temperatures, and in tissues, yeast is heat, and so that's what it looks like once they're in the body. So endemic mycosis includes blastomycosis, coccidioidomycosis, paracoccidioidomycosis, emergomycosis, histoplasmosis, sporotrichosis, and teluromyces. In South Africa, we are endemic for blastomycosis, emergo, histo, sporotrichosis. And so those will be the 4 that I'll be discussing in a bit more detail later on. It's also important to remember that there are AIDS-associated mycoses, and these are namely histoplasmosis, emergomycosis, and teluromyces, which are associated with advanced retroviral disease. So this is just a nice illustration just to contextualize the types of fungal infections. So you can divide them into anatomical categories, so mucocutaneous infections, deep organ infections. You can base them on morphology, so are they molds, yeast, dimorphic fungi, and then epidemiological categories, so are they opportunistic mycoses, endemic mycosis, which is where we're talking. So this is what we're talking about today. So how does one acquire endemic fungi? Well, they are found in the soil environment, and so disturbance of the soil leads to aerosolization of the conidia, and through microscopic breaks in the skin, you may have traumatic inoculation of these fungi. The other way, which is most common, is also inhalation of these conidia. So once they're inhaled, they're ingested by the macrophages within the lungs, and then they germinate into the yeast form because of the temperature changes, and then they're able to replicate. Once they undergo this transition into the yeast form and begin replication, there's a few things that happen that allow it to evade the host's immune defense and to cause disease. So it undergoes remodeling of the cell wall, which causes reorganization of the glucan content, which has the potential to impede the pathogenic molecular patterns by the host immune cells. It can also upregulates these yeast-specific genes to actively subvert the host immune defenses. So it inhibits activation of the CD4 T lymphocytes, and so reduces production of interleukin-17 and interferon gamma. It binds yeast to host cells with complement receptors and heparin sulfate. It also inhibits production of tumor necrosis factor alpha by macrophages and neutrophils. And tumor necrosis factor alpha is quite important for proper host defense against these dimorphic fungi. And when we talk about risk factors, it comes up as a specific risk factor for acquisition of these fungi. And it cleaves these colony stimulating factors which reduce macrophage and neutrophil activation. So does quite a lot in terms of immune activation. And then it can disseminate from the lung to the rest of the body via reticular endothelial system. So the determinants of the disease depends on a number of things. One is the inoculum quantity. So how much were you exposed to? For how long were you exposed to it? The virulence of the organism, and obviously the host's immune response. So when we're looking at risk factors for endemic mycosis, you can divide them into exogenous factors and endogenous factors. So exogenous factors relates to human activities, which may either be occupational or recreational. So travel, obviously, to endemic areas is a big risk factor. The number of international travelers that actually acquire systemic endemic mycosis remains unclear. And this is for a number of reasons. One is that endemic mycosis is not a notifiable disease. And oftentimes, these patients are diagnosed when they return back to their home countries. Some of them may have cleared the infection by the time that they've, before they've sought any medical care. And so the exact number is really not known. Dust storms and earthquakes, similarly, are risk factors for acquisition because this disturbs the soil environment and causes aerosolization of the conidia, and so makes people at risk of inhalation. And then laboratory workers, quite important to remember, who handle these suspected samples are also at risk. So each of the endemic mycoses have specific exogenous risk factors. So there are certain areas that these fungi thrive. And so when we're taking a history, we need to specifically ask about this. So where did they go? What did they do? Where do they work? What exactly were they doing? Where did they stay? Because all of this can give us clues as to which mycosis it could be. So blastomycosis thrives in wooded land with damp soil that's near lakes and waterways and rivers. So manual laborers, hunters, farmers, forestry workers, camping, canoeing, fishing, wood chopping, working with compost, road construction, disturbing beaver dams. So all of this in relation to rotting and decaying wood can predispose you to getting blastomycosis. Coccidioidomycosis is found in sandy and alkaline soils, and that is usually where there's construction work, where the farmers are, so rural workers, construction workers in contact with soil are at risk. Paracoccidioides, also humid, rainy forested areas near rivers, people who do armadillo hunting, agricultural exposure, where there's coffee and tobacco crops because the soil is quite acidic, are also at risk of paracoccidioidomycosis. Large-scale construction projects that disturb the soil also make them at risk. Histoplasmosis grows very well in organic matter that's enriched by bird and bat droppings. So rural workers, speleologists who work in caves, tourists in contact with bird or bat guana and soil are at risk. So caves with bats, chicken coops, bird roosts are all potential sources of exposure. Sporotrichosis is found globally in soil and in decaying plant matter. So agricultural work, mining, hunting, so anything that has contact, where you're in contact with contaminated plant water may put you at risk, and exposure to cats, but as well as dogs and armadillos and birds and parrots may also put you at risk for sporotrichosis. Emergomycosis, it's thought to be contact with soil associated with agriculture and horticulture, and soil associated with the plants that are endemic to the Cape Floral Kingdom in the Western Cape. And Telleromyces is also found in soil, so farm workers are more at risk. So very important to ask specific questions in relation to all these exposures so that we can get a clue as to which potential endemic mycosis our patients could be suffering from. So this is just a map illustrating the certain geographical areas that these specific dimorphic fungi are restricted to. So this is obviously related to the climatic conditions, the degree of humidity, precipitation, and soil water storage, like I had mentioned. So we can see here, these are all color-coded, and it just illustrates where the various mycoses are. For us, sporotrichosis and emergomycosis, and a bit of histoplasmosis is what's illustrated in this map. Now, though, it's the geographical landscape of these dimorphic fungi have actually expanded. And the reason for this is because of human movement. So immigration, tourism, professional trips can make what is thought to be endemic to a certain area actually occur in an area that's not known to be endemic for that particular disease. Global warming, So this causes adaptive thermotolerant species that have significant pathogenic potential. So the changes in climate and temperature may also influence and expand the areas in which you may find these dimorphic fungi. And the other thing is that there's an increased prevalence of immunocompromised patients, whether that's related to HIV or other immunosuppressing conditions, that has also expanded the area in which you find these so-called endemic mycosis. And then the improved awareness and better diagnostics in terms of trying to culture and identify these dimorphic fungi have actually expanded these areas that were previously thought to be restricted only to certain places. So this is a bit of a busy slide, but it's a nice paper by Li and Lau in 2017. And this just illustrates the areas that are endemic for all these systemic mycoses, and then what exposures and occupations would put you at risk for acquiring them. Then I come to endogenous factors. So any immunosuppressing condition that affects your innate and adaptive immunity, that affects cytokine signaling, that reduces your CD4 count, can all predispose you to endemic mycosis. So advanced HIV, transplant patients, patients with malignancies, diabetes mellitus, Cushing's, patients on immunosuppressants for autoimmune disease, especially anti-TNF agents. And it's actually been put as a warning for patients who have been on anti-TNF agents that there is a risk of acquiring these endemic mycoses. And primary immunodeficiencies, there's still ongoing work looking at specific immunodeficiencies that predispose to fungal infections. So they haven't pinpointed specific conditions as yet, but also just to emphasize, disease can occur in individuals without any of these risk factors. So again, depends on the inoculum size, how long you were exposed to it, and where you went. So just to bear in mind that it's not just those who are advanced immunosuppression that can present with these diseases. Perfectly healthy individuals can present with features suggestive of endemic mycosis. So what's the case in South Africa? So prior to this talk, I actually was quite uneducated about how many cases we had in the country. So this was sporotrichosis in infections that were diagnosed in the mines in the Witwatersrand area. This is from 1941 to 1943 that they found 2,441 cases of sporotrichosis at Ventersport mine. And then again in 1944, discovered 384 cases at a consolidated main reef mine. And the source of the fungus was thought to be on the wooden mine props that were being used. There was also another outbreak reported in 1957 of acute pneumonitis secondary to histoplasmosis. And this is where 3 students presented with features of acute respiratory illness 2 weeks after exploring limestone caves in the Eastern Cape. And they found that these caves had a very deep layer of bat guana and were exposed to dusty atmospheres for several hours. And then again in 1953, 4 adults who explored limestone caves in the Tambazimbi area, who went there to check the mines to see if this bat guana was good fertilizer, also presented with acute respiratory illness. And they were all found to have histoplasmosis, but this was based on skin tests. Then this is another study, a paper in 1997 that looked at 42 suburbs in Pretoria and 23 towns outside of the Pretoria municipal boundary, where 154 patients were diagnosed with sporotrichosis. And then this was in 2011, looking at a sporotrichosis outbreak in gold mine workers in Barberton. And the prevalence in this study was found to be 20% amongst those mine workers. So this is a paper taken, this was in 2017, and it looked at AIDS-related endemic mycosis in the Western Cape and clinical mimics. So what they did here is they took HIV positive patients with cutaneous lesions caused by systemic mycosis endemic to South Africa, and they tried to see what features could differentiate it from other dermatoses. So it was a 2-year study from 2014 to 2016 in Cape Town. They recruited patients who were over the age of 18, who were HIV positive with a CD4 count less than 100, and the median CD4 was about 28. And these patients presented with widespread cutaneous lesions that were present for less than 6 months. And they were considered by the attending clinician to be compatible with a systemic mycosis, Once that was done, these patients were then reviewed by a dermatologist who was blinded to the diagnosis, and 2 skin biopsies were taken from each patient. So in total, they had 34 patients that were analyzed, and of these 34, 25 had proven mycosis on histopathology. So 14 patients were diagnosed with emergomycosis africanus, 3 with histoplasmosis capsulatum, 3 with sporotrichosis schneckii, and 5 they couldn't identify the exact fungal species. And this table I just wanted to take out to illustrate really the diverse cutaneous manifestations that these patients have. It ranges from plaques, papules, patches, nodules, ulcerations to erythema, really non-specific cutaneous lesions. And a significant proportion of these patients came back positive on histopath for these endemic mycosis. These are pictures taken from the same paper. And you can see here, just the first 5 all have very different cutaneous manifestations, but the first 5 all were diagnosed with emergomycosis africanus. The next 3 are all the same, sporotrichosis, and the last 3 are histoplasma capsulatum. So you can see the diverse cutaneous manifestations of these diseases. This was another paper in 2019 that looked at the estimated burden of fungal diseases in South Africa, and they looked at the population characteristics and underlying comorbidities in South Africa using various registries, and they estimated cases. So these are not proven cases, but they're using the registries and the number of case reports that that were present. They estimated that these were the number of cases that we would have per year. So the emergomycosis 100 per year, histoplasmosis 60, sporotrichosis 40, blastomycosis 10, and chromoblastomycosis 40 per year. So this is a study done by the NICD. So they looked at endemic mycosis in South Africa over a 10-year period. It was a passive surveillance that was initiated by the NICD for endemic mycosis in 2014, and they reviewed cases at both public and private laboratories over this 10-year period. So they took demographic, clinical presentation, HIV status from the request forms, and they did a retrospective electronic review of the laboratory diagnosed cases of disease caused by these thermally dimorphic fungi. So they took reports from microbiology, histopathology that was affiliated to the NHLS, one large private pathology lab which serves 40% of the private healthcare market in South Africa, and the referred cases that were sent to NICD for further diagnostics. So in total, they had 682 cases over this 10-year period. And the case definitions was follows: proven cases, probable cases, possible cases. So proven cases were, you had, there were thermally dimorphic fungi that were cultured by phenotype, or they were confirmed by molecular methods from the clinical specimen. Probable, where you had morphologically consistent yeast that were observed on histo, and either the urine histoplasma antigen was positive or the pan-dimorphic assay was positive. And then possible, is where you had the compatible clinical syndrome, which was consistent with the tissue inflammatory infiltrate, but there were no yeasts observed. So just to, so I'll just move on to this graph. So just to give you an idea, sporotrichosis came up as the #1 endemic mycosis for us, accounting for 25% of cases. The highest numbers being in Gauteng and KZN, followed by emergomycosis at 23%, the highest being in the Western Cape, followed by Gauteng, then histoplasmosis at 20%, highest being in KZN, Western Cape, then blastomycosis at 2%, that was highest in the Eastern Cape and the Western Cape. And for telleromyces, there were 4 imported cases, and all these patients had travel histories. And then the 207 cases, they were unspecified, so they weren't able to tell which, they weren't able to speciate it. So all these endemic mycosis occurred through all 9 provinces, but leading provinces were Gauteng and the Western Cape. This was just a table taken from them looking at the demographic data, but I just wanted to highlight that the patients who did present with HIV were severely immunocompromised, all had CD4 counts less than 100. And then the other thing is that the most common clinical specimen that was submitted for investigation was skin biopsies. So in terms of the different diagnostic methods that they used, histopathology found 40% of cases, culture with phenotype with a PCR were diagnosed that constituted 24% of cases. Just culture and phenotype were 18%. The urine histoplasma antigen tests were 15%, and the pan-dimorphic PCR diagnosed 0.4% of cases. So now I'll move on to the clinical features of the endemic mycoses. So I'm going to, for each of them, I'm going to give a clue, and then we can guess which one it is. So we'll start off with this one. So which endemic mycosis could this be? Jeremy, I'm not sure if you can do polls, but just to give an idea. So in this particular mycosis, you have these typical skin lesions, you have pulmonary involvement, you have a dog there with a lesion, and this is the area in which this mycosis is found in. So Jeremy, I'm not sure if you can help with the polls. Oh, thanks. So is it A, sporotrichosis, B, histoplasmosis, C, blastomycosis, or D, emergomycosis?
Okay, we'll give people another 5 seconds. Okay, ending the poll and sharing the results. You just have to read them out.
Thank you. So 47% of the participants thought it was blastomycosis, followed by 31% with histoplasmosis, and then sporo and emergomycosis being 10 and 12%. So this is actually blastomycosis. So it includes the species Blastomycosis dermatitidis, Gilchristi, Pertussis, Helicus, Parvus, and Silverae. It was first described in 1894 by Gilchrist as a protozoan infection, and then later identified as a fungus. Because of its geographical location from where it was first diagnosed, they were colloquial names in the earlier 20th century. So it was known as Gilchrist disease, Chicago disease, North American blastomycosis. The microbiology, just briefly, so this is the hyphal form. So at 22 to 25 degrees, it grows as these septated hyphae, which are about 1 to 2 micrometers in diameter, and that produce these small conidiae, which is attached to a very short conidiophore, which resembles a lollipop. So this is a nice illustration here. And then the yeast form, which ranges in size from 8 to 20 micrometers, is characterized by these doubly refractile cell walls with multiple nuclei and broad base budding pattern between mother and daughter cells. So the epidemiology, so it's mainly in the US, so the Midwest, South Central, Southeast US, and Canadian provinces of Quebec, Ontario, Manitoba, and Saskatchewan. But there are some cases in Africa and India, and in South Africa, like I had mentioned, the cases were reported mainly in the Eastern Cape and the Western Cape. The clinical features here are quite interesting, that 50% of patients can be symptomatic and the other 50 are often asymptomatic. And the incubation period for this is 3 to 12 weeks. And it's been described in the literature as being the great pretender. So if we think back to how we acquire endemic mycosis, first is either through traumatic inoculation, so you have cutaneous manifestations, or inhalation of the conidia, so you have pulmonary manifestations. So all the endemic mycosis will have pulmonary involvement as well as cutaneous findings. So pulmonary involvement here is 69 to 93%, who present with pneumonia, and the spectrum really can be varied. So you can have asymptomatic infection to a brief influenza-like illness to acute pneumonia, ARDS, and then chronic pneumonia. And the radiological findings are really non-specific. So you can have lobar consolidation, masses, interstitial infiltrates, nodules, and I'll show you some of the images as we go through the slides. So this is here just illustrating lobar consolidation with a nice tree and bud appearance here with the air bronchograms. This is a multi-lobar pneumonia, bilateral infiltrates. These are nodules here, so this nodular pattern. You can see fibrotic changes here, and this is a mass-like lesion. And all these patients had come back diagnosed with blastomycosis. And you can see the clinical spectrum here is really varied, not specific, and often can be confused with other things. Obviously, in our country, TB being the number one thing that we would confuse this with. Then the extrapulmonary manifestations, so cutaneous. So the papules typically for blastomycosis have been described as these varicose ulcerated lesions. They may involve the scalp, the face, the trunk, and extremities, and they can be solitary lesions that are large and destructive and that heal with scarring. The bone is also affected, so 15 to 44% of patients present with this localized pain and swelling with sinus tract formation, and it's commonly the vertebral bodies, long bones, and ribs that are involved. Genitourinary was previously thought to be 20 to 30%, but is actually less than 10% now. And it's more common in men with prostatitis, epididymoorchitis, and in women, endometritis, salpingitis, and tubo-ovarian abscesses. And CNS is documented to be less than 10%, but they can present with meningitis, brain abscesses, intracranial masses. So these pictures here are just to illustrate the cutaneous manifestations. So you can see here these varicose ulcerative lesions, and here's the osteoarticular involvement where you have these lytic lesions of the bone. The dog is also a clue. Dogs are particularly prone to blastomycosis, and so in the Americas, the ill dog is actually an ill dog with these cutaneous and pulmonary manifestations usually gives a clue to if their owner is sick or the people in the neighborhood that are sick, to the potential of blastomycosis, because they are quite prone to developing canine blastomycosis. And then the area, like I had mentioned before, in terms of exposure, is usually these wooded lands with damp soil that are usually near lakes or waterways and rivers. The next one is this. So this is a patient with a very bad pneumonia. There are bats, there are caves, and there's bird coops. So which endemic mycosis could this be? So A, sporotrichosis, B, histoplasmosis, C, blastomycosis, or D, emergomycosis.
Okay, going to give 5 seconds more. Okay, ending the poll.
Great. So the majority, so 79% have said histoplasmosis, and then 14% have said sporotrichosis. So the correct answer is histoplasmosis. So this includes histoplasma capsulatum var capsulatum and histoplasma capsulatum var dubiesi. The microbiology, again, very briefly. So the micelle forms are brown and albino with these macroconidiae with tuberculates and microconidiae, and the yeast are these small multipolar budding forms. The epidemiology is that it can affect every continent except Antarctica, and was first mainly diagnosed in Ohio and Mississippi River valleys in the US. It was first discovered in 1905 when Samuel Darling, who was a pathologist in Panama, examined the visceral tissues and bone marrow from a man in Martinique whose original cause of death was thought to be miliary TB. And then when seen through the microscope, he actually saw these small intracellular bodies that were thought to be protozoan. And then when it was later reviewed in 1912, were actually diagnosed as being yeast. So histoplasmosis has often been confused quite commonly with TB. So the clinical features, again, pulmonary. So 90% go unrecognized because they're either asymptomatic or they have a very mild influenza-like illness, so they get better without any treatment. Acute histoplasmosis has an incubation period of about 1 to 3 weeks, and they present with this pneumonia, erythema nodosum, arthralgia, and about 6% of cases can be complicated by pericarditis. And then chronic histoplasmosis can present with these pulmonary cavities, which again can be confused with TB. Extrapulmonary manifestations, you have ocular, CNS, endovascular, cutaneous, and bone. And again, the cutaneous manifestations can be ulcers, nodules, psoriasis-like lesions, cold abscesses with osteolytic bone. So really can also be quite diverse. And it's thought to be more, the cutaneous manifestations have been associated more with histoplasma capsulatum var dubiesi more than var capsulatum. So this is just pictures illustrating the pulmonary findings. So you can see here bilateral infiltrates, almost this miliary-like pattern, easy to confuse with TB. And then with the cutaneous manifestations, you have these nodular lesions. You can have papules, macules, ulcers, and these acne-like lesions. So really can be quite diverse and not really specific. And like I'd mentioned earlier, that histoplasma thrives in soil that's been contaminated by bat and bird guano. So it loves caves. So people who go exploring caves, do splunking, and are quite at risk of getting histoplasmosis. And now this one, so this is the clue. You have cutaneous manifestations here. I've highlighted a province in South Africa, and then lovely flowers in front of one of the famous mountains in that particular province. I think this should be quite clear cut. So do we think A, it's sporotrichosis, B, histoplasmosis, C, blastomycosis, or D, emergomycosis?
Okay, just 5 more seconds.
Okay, so this is interesting. So 52% have said it's sporotrichosis and 45% have said emergomycosis. So the answer is actually emergomycosis. So emergomycosis was actually thought to be an Emonsia-like organism. Because of the taxonomy, it was classified as its own genus in 2017, and there have been 7 species that have been described. So E. pasteurans, canadensis, orientalis, europaeus, africanus, crescensis, and sola. And E. africanus is what is endemic to South Africa and what is endemic to the Western Cape. So the microbiology here is very briefly, so these are slender conidiophores. So if you look at this highlighted version of the hyphal forms here, you have the slender conidioforms that form hyphae at right angles, and they form florets of short secondary conidiophores that bear single small subspherical conidia. And the yeast phase here shows round to oval yeast cells with narrow-based budding. And the epidemiology here, it has been described in Europe, Asia, North America, but primarily emergomycosis africanus has been diagnosed in South Africa, and particularly in the Western Cape. I think there was one case in Lesotho and one case up north of Africa that have been diagnosed outside of South Africa. So it is endemic, and it's something that we should be considering for our patients in South Africa who we think may have these deep fungal infections. Again, the clinical features are either cutaneous or pulmonary. Really, the cases of emergomycosis that have been described in South Africa have been with disseminated disease. So there are patients who have lung, GIT, liver, spleen, marrow, lymph node involvement, and the skin has these umbilicated papules that may be confused with molluscum, nodules, ulcers, verrucous lesions, crusted hyperkeratotic plaques, and erythema. So these pictures just illustrate the cutaneous manifestations. And in South Africa, 86% of patients were found to have abnormal chest X-ray findings. And again, these were quite non-specific. So they had reticular nodular patterns, consolidation, pleural effusions, hilar lymphadenopathy. So really quite diverse here. And then the last endemic mycosis I'm going to speak about. So these are the skin lesions. That's a cat there. And then this is a rose garden. So do we think it's A, sporotrichosis, B, histoplasmosis, C, blastomycosis, or D, emergomycosis?
Yeah, 5 seconds. Cool.
Great. So 94% have said sporotrichosis, which is the correct answer. So sporotrichosis includes sporotrichosis schneckii, brasiliensis, mexicana, pallida, globus. And like we had said, they're usually found in soil. So people who do a lot of agricultural work are exposed to it, and it was quite famously known as rose gardener's disease. So the microbiology, just quickly, you have colonies that are brown to black. You can see here in the picture on the left with mold. And this is because of the pigment that is produced, these pigmented conidiae. And then if you look at the hyphal forms, it shows these pyriform conidiae in a flower-like arrangement. So they look like a bunch of flowers. And the yeast phase, where the arrows are pointed, shows oval or cigar-shaped budding yeast. The epidemiology is that it's global, but tropical and subtropical regions of the Americas have been known to have large outbreaks of sporotrichosis. The clinical features here, mainly cutaneous, because it's usually from traumatic inoculation. And they start with papulonodular erythematous nodules that become smooth or varicose and ulcerate. It starts at a distal extremity and it moves proximally along lymphatic channels. And the subsequent lesions that develop are similar to the primary lesion, and it's usually associated with lymphadenopathy. It's also important to recognize that you can have fixed sporotrichosis, so not just these migratory skin nodules where the lesions don't spread and they just remain at that site of inoculation. And it does have extracutaneous manifestations, so you can have osteoarticular involvement, and this affects usually the major joints of the extremities, so patients can have synovitis with sinus tracts. And then pulmonary and multifocal extracutaneous sporotrichosis usually presents with cavitatory lesions in the lung with parenchymal infiltrates, and you can have quite extensive cutaneous disease. So the picture here on the top left is fixed sporotrichosis. The one at the bottom here is the lymphocutaneous sporotrichosis. This picture shows quite extensive sporotrichosis in a patient with advanced retroviral disease. You see lesions bilaterally, so it doesn't always have to be unilateral. And then this is X-ray images of the same patient with quite severe osteoarticular involvement of the hands and forearms. So coming to diagnostics for endemic mycosis, histopathology and culture have remained the gold standard in terms of diagnosis of these endemic mycoses. There are a few issues though. You do need BSL-3 for processing some of the specimens. So for example, histoplasmosis needs a BSL-3 lab, coccidioidomycosis also needs BSL-3 labs, and you do need trained personnel to do this. So resources is a big thing. It takes about 4 to 6 weeks for the culture to come back, and you are required to confirm dimorphism. So it does take time. It's not a quick test in terms of getting an answer, and it does lack sensitivity. So studies have shown that it takes about, the sensitivity of culture is about 30 to 50%, and it depends on the degree, the burden of disease, the degree of immunosuppression. So for example, in sporotrichosis, the histology may be negative due to the small number of microorganisms that are actually needed to cause disease. So just in terms of how they confirm the dimorphism with these isolates is that you have the mold face isolates, which are then subcultured onto a saboride agar and incubated at 25 and 30 degrees for 4 weeks. And then for the yeast phase, a piece of that mold from the saboride is subcultured onto this brain heart infusion and 5% sheep blood agar slope and incubated for a further 1 to 4 weeks at 35 degrees. And the growth on both will confirm the dimorphism because they're different temperatures at which they're being incubated. The antibody test really depends on the degree of immunosuppression. It may remain positive for a long time following infection. And the problem here is that there's cross-reactivity among endemic mycosis causing species. So it's not specific for a particular mycosis, they can cross-react with the others. So it's actually not done, and we don't actually offer it here. But if you read about it in the textbooks, they do talk about the use of antibody tests, but bearing in mind those limitations. Antigen tests are useful in severe immunosuppression and in the case of disseminated disease. Again, the issue here is that it cross-reacts with other endemic mycosis species, but it has a shorter turnaround time. It is non-invasive. You don't need specialized facilities. And so it's quite appealing to have it available because it provides a faster way of diagnosing these endemic mycoses. You have specific PCR assays. So for example, with Histoplasma capsulatum, you can target different genomic regions. So you look at rRNA multi-copy regions in 18S, ITS1, and ITS2 regions, and ribosomal small subunit RNAs. You can also look at unicopy targets as genes coding the M antigen, PPK, and CFP4 genes, but the sensitivity has been reported to be 70 to 100% in published studies. But it's important here to realize, to just acknowledge that there's various methods and assays that are used in different laboratories across the world. So there's really no consensus or standard as to which method or assays should be used. And I think that's still in development. Then you have the broad range PCR, which looks at fungal or fungal group specific primers to amplify fungal DNA directly from clinical samples, followed by identification, mainly Sanger sequencing to confirm the causative agent. But again, this also has issues with sample contamination, detection of commensal fungi, and lacks an adequate fungal database, because once you sequence it, you need to compare it to what you have in the database in order to get an ID. So what do we have in South Africa? So the first thing is always inform the lab of a suspected case. Again, it's not only that they do the correct test, but it's also that they take the proper precautions in terms of processing of these specimens. So we have culture with phenotypic identification. So we do microscopic identification, usually with staining, which can be the chalcofluor, gomorymethamine silver past stains. You need to confirm dimorphism, as I explained previously. And you do need to process the histology specimens and suspected histoplasmosis cases in BSL-3 labs. We do have pan-fungal PCRs available, so it can be done from either fresh tissue or a cultured specimen. And here they target specific ribosomal areas, so the ITS1 and ITS4. And if you have difficulty identifying those two regions, then another region is looked at, which is called the LSU. And this is often done for cultured isolates. But if it's a tissue that has been sent for diagnostics, then all three targeted areas are looked at. You do have species-specific PCR targets. So for example, with sporotrichosis, they try and identify the calmodulin gene, which is specific to sporo. And this is followed obviously by, this is after they've done the ITS and LSU PCRs. There is real-time PCR for histoplasmosis and emergomyces, and you can do this directly off the clinical specimen, and it detects histo or emergomycosis. It's not easy to tell them apart, and again, it can cross-react with blastomyces, so this is a problem. And then you have the EIA for histoplasmosis. So what we have here is the IMMY Claris H. capsulatum EIA, and this is the urine histoplasma antigen that we request, and it's found to be more, you get more yield with disseminated disease and those with advanced retroviral disease. But again, the issue here is that it cross-reacts with other species, so emergomycosis, blastomycosis, and paracoccidioidomycosis. And the sensitivity in a South African study done was 88% with a specificity of 72%. And currently the NICD is validating a latex agglutination test for histoplasma capsulatum specifically to detect that doesn't cross-react with emergomyces. So mainly in our setting, we have culture, we have pan-fungal PCR, we have real-time PCR for histoplasma and emergomyces, and EIA for histoplasmosis. So my last two slides is just looking at treatment of endemic mycosis. So this is a guideline taken from the European Confederation of Medical Mycology, and it was developed in 2021 to provide a consensus and guidance in management of endemic mycosis. I've summarized it in one slide because essentially all treatment has an induction and maintenance phase. So the induction phase of treatment is usually with liposomal amphotericin B or an alternative amphotericin B formulation, and that's usually 1 to 2 weeks. And then maintenance treatment is with a triazole. So itraconazole is the one that's been most studied, and usually this is given for 6 to 12 months, depending on the site of disease and the degree of immunosuppression. Emergomycosis, the treatment here really is based on observational data. It has been noted to have high fluconazole MICs, and so the recommendation is to use amphotericin and itraconazole, and the duration of therapy has not yet been established, but they've taken the same line as the treatment duration for histoplasmosis, and so most people follow those treatment recommendations, which is essentially the 1 to 2 weeks of induction with 6 to 12 months of itraconazole as maintenance. And then it's noted that mild and moderate disease can be treated with itraconazole alone. So my take-home points from this endemic mycosis talk, and I hope that we think of it now more often, because it is something that happens in South Africa. I used to think, and I'm guilty of this, that these endemic mycoses only happen in the Americas, up north in Africa, and doesn't really happen in South Africa. And looking back at these cases and looking at the work done by the NICD, you can see that we are endemic for a lot of these mycoses. And the problem is that we don't think of it often as a differential diagnosis, especially in our setting where TB, obviously the pretest probability, we think TB number one because of how much we have around. We really should consider this as a differential in patients whose TB workups are negative, who are not responding to TB treatment because it is there. It's important to note that it's not a notifiable disease in South Africa. And so we don't actually know the true prevalence of endemic mycosis here. But I hope that with the exposure history, with the pulmonary and cutaneous findings, that we start to think of it a bit more, and also send off these specimens for these particular tests and inform the lab, because we do have it available and we are able to diagnose it in our setting. And with that, I'll thank you, and a special thanks to Tsidiso Mapanga and Suresha Naika from the NICD's mycology department for their help with the diagnostics. Thanks, Jeremy.
Great, thanks so much, Sharon. That's fantastic, and again, I do think it's worth perhaps reiterating what a really good mycology unit exists at the NICD in terms of the scientists and the clinical microbiologists and things together. I mean, there have been new species discovered, in terms of these endemics. I don't know, CD, if you want to blow the horn for blastomycosis mzansi quickly. Or not. Yes, you can go ahead. Go ahead, Steve.
Good day, everyone. I'm Tsidiso Mapanga. Yes, we have discovered a new species. Hello, can you hear me?
We can hear you, Tsidi.
Okay, yes, we have discovered a new species, a new blastospecies actually from blastomycosis cases, which were diagnosed between 1967 to 2014. So this isolates, or these cases from these isolates from these cases were previously identified as blastomycosis dermatitis by culture methods. Then, following with the introduction of molecular methods, we went back and to our archives, and then we tried to see if really these cases were were caused by blastomycosis dermatitis, and we found that actually there were like two different species that were causing this infections, of which one was blastomycosis dermatitis and the other one was blastomycosis mzansi. So they had like similar clinical presentations, all the cases presented with extrapulmonary diseases. So yeah. So this blastomycosis mzansi, the Peccasus one is actually found even in Africa. It's not only limited to South Africa, but mzansi, it was actually our species. That is why we decided to call it blastomycosis mzansi, because it was only reported in South Africa.
Yeah, thank you. It really is the best name. Yeah, they came up with a disaster, but it really great stuff, and it's really cutting edge stuff that the NICD's mycology team does. I just wanted to open the floor to any of the other scientists from the mycology lab if they want to add any comments or additional points, and otherwise we can move on to questions if there's no additional comments at this point. But open the floor to anyone else. You're welcome to unmute from the lab.
Just to mention, Jeremy, that we urge actually the diagnostic labs that if they like see or query endemic mycosis, they can actually since we know that, this histoplasmosis and the thermally dimorphic pathogens, they take quite long to grow. So it is very much important that when they culture this pathogens, they incubate for longer so that we don't miss these pathogens, that we are able to actually identify them. Because if you incubate for maybe less than 3 days or 7 days and you throw the plate, we won't be able to pick like your histoplasma or your blasto. So we urge them to actually, maybe if they suspect endemic mycosis, they can incubate those plates for a longer period. For example, with a major, maybe for 14 days, and for histo for almost a month. We'll really, really appreciate that, so that we don't miss these important pathogens.
Yeah, I think that's a great point. As you said, to make sure that the lab is incubating long enough. Even the sort of standard, I think, that one of the microbiologists must correct me, but I think usually the standard NHLS, if you tell them we're looking for fungus, is about 2 weeks. But as you say, that may not be long enough. You do need to incubate potentially for even longer. But I do stand to be correct about the duration. But I think that's the case. John, you've got your hand up?
Yes, thanks. So Sharon suggested that most blasto cases came from the Western Cape, but I'm not sure that's right. Certainly the earlier reviews suggested that the further north you go, the more cases, well, certainly in our series, the majority of cases seem to come from Limpopo and Zimbabwe. I don't know if maybe that was just because of referral patterns. I don't know. Anyway, I don't think. No.
Yeah, I think it was just taken from that, just from the one paper, and they were just looking at the cases that were referred to them. So in that particular paper, the rate or the incidence was found to be greater in the Western Cape and Eastern Cape. But obviously that's not, it doesn't hold true for all the cases. It was just for that particular case series during that particular period, when they looked at where the specimens had come from, those two provinces were ranked as being where they had noted those 2% of blastomycosis cases. So that was that NICD surveillance study that they did from 2010 to 2020.
Okay, interesting. I don't know if anyone from the mycology lab wants to add anything about that. In your kind of, yeah.
Hey, Jeremy, are we talking about a study that we did with Rutendo, the 2010 to 2020? Are we referring to that study?
Yeah, CD, I'm referring to that study, yeah.
Oh,
yeah.
Sorry, I missed Prof's question. What was Prof's question?
No problem. I think Rutendo's got her hand up as well, but it's about where the majority of the cases were from. Was it?
Okay. So those actually were from culture. I think the diagnostic labs, because they were not confirmed by PCR. When the diagnostic, they try to ID. Whatever is sent out, they send it out as based on a phenotypic ID. They send it out as maybe as blast or emergomycosis without confirming with molecular. So that's what those cases are coming from. Because the confirmed cases that I know of from, I think it was about 5 that were confirmed by molecular from those 14. Rutendo?
And sorry, it's Ruth. Ruth who's got a hand up, sorry. But Rutendo, you're welcome to shut up. Otherwise, Ruth, you can go ahead.
Okay, mine is different. It's not a comment on this. So Rutendo can go and then I'll say my piece afterwards.
Okay, hi everyone. To answer Prof's question, we tried to look at where the cases are coming from, and that was very difficult in our case because most people acquire them from other places, and then when they get sick, probably they would have moved to the bigger cities. So that's why most of the cases were reported maybe in the Western Cape, because of the better facilities and better hospitals that they have, and also in Gauteng. But that is not reflective of where these people are actually acquiring the disease itself. So in most cases, you find that because of so much movement, probably they are acquiring the infections in Zimbabwe or places like that, and then they just go and settle, and by the time they get sick, because most of these diseases, they can stay in someone's system for even up to 50 years. So I think in my discussion, I went on to say it's difficult to actually pinpoint the source based on these cases, because of the lack of knowledge of where people might have been in the past 30 or so years. It becomes difficult to say this is where they're exactly getting it. It's now more based on where it was diagnosed.
Yeah, I think that's a really, really good point, because as you said, I think that's a underappreciated thing, that it may be a very long duration between acquisition of the infection and actual clinical manifestations. Or exposure, should I say, and clinical manifestations of the disease. So you rightly said that, people have maybe moved decades away or decades ago. Ruth?
Okay, thanks, Sharon, for the great presentation, and thanks, Jeremy. So I just wanted to make a call to everyone, because we've been meaning to send a letter that if anyone has a suspicious case, we are doing a validation on a qPCR assay for these dimorphics. So if you have blood, CSF, bone marrow, or serum, we have a PCR that we are validating that can actually assist in identifying these if we don't have growth, and as well as when you send us the urine. So if you're a patient, you're taking urine, and then you also maybe have blood, so you can please send it through. Thanks.
That's excellent. And just for those who are not as familiar, so this is the mycology reference lab at the NICD. So you can find them on the NICD website in terms of contact details if you need. Okay, I think we have to end it there. I guess just one question for me, if you don't mind, because my prerogative is as host here. I mean, what strikes me, Sharon, in that when you showed the incidence of cases, it sort of peaked around 2015, and then they've been on decline since then. I just wondered, because it's certainly something I've noticed anecdotally. I mean, when in about 2015, we were diagnosing about a case every month or two, Helen Joseph, of these dimorphics, and now it's been, I think, better part of a year since we last saw one. What do we think? What do we put that down to? I think, Rutendo, you've got your hand up. I don't know if it's in response to that. I mean, clearly the HIV epidemic is getting a bit better, but I wonder if it's just that. Yeah, you can go ahead.
Yes, so thanks, Sharon, for the beautiful presentation. But I actually always talk about that peak in 2015 that we see in that graph. So this was mainly attributed to another research that was being done in the Western Cape, the one that you also talked about, where they were following real cases in the hospitals. So because of that awareness, and someone was actually looking for these diseases, we saw a high number of cases being reported in this period. And when that study ended, then the cases sort of went down. So that just tells us that they are there, but I think that we are missing them to a larger extent. So that peak is mainly due to that study that was being done in the Western Cape on endemic mycosis during that period.
Okay, thank you very much. That's a great explanation. Solved that mystery for me.
Yeah, I think also, oh, sorry.
Go ahead.
My last comment was just that I think we just don't think of it enough. I think, like I said, a lot of it is misdiagnosed as TB, which is not necessarily wrong in our setting. But I think that we do need to start thinking about it a whole lot more, and we do have access to investigations to look for it. And I think that if we search, we probably will find more, just like Rutendo said. Like they were looking hard during that time and they found them. So I'm sure if we start doing the same, we probably will hit a peak again with the cases.
Yeah, I agreed fully. I think it's a bit scary how much we miss at a national level. Okay, great. Thank you so much, Sharon. A lovely talk. And thank you so much to the mycology team from the NICT for being present, the scientists. You really added a lot, and it's great to have such good expertise around.